An important topic called the Tinel sign, right? We're going to do a short video today regarding the Tinel sign. It's very important topic both for your OSCE, for your Viva OC, as well as for your theory exam. So you must know this very well. You know, a lot of students make mistakes with this Tinel sign. So all of you should know this very well, right? So what is Tinel sign? Tinel sign is basically when you tap on a regenerating nerve, right? When you tap on a regenerating nerve, the axons, the sprouting axons, give a current shock like sensation. The sprouting axons give a current shock like sensation, and this is called as a Tinel sign. So basically Tinel sign is when you tap or percuss. So you can see the finger that is percussing here. When you percuss on a damaged nerve where the nerves there is sprouting axons at the end, this causes a current shock like sensation in the area supplied by the nerve or at the point of the damage to the nerve, and this is called as the Tinel sign. So there are two types you can say about Tinel sign. One is, so Tinel sign can be a static sign. We can test it statically or you can test it dynamically, right? So what is the difference between these two types? Static is, for example, in a case like carpal tunnel syndrome where the compression is right at the carpal tunnel, and therefore you will have some kind of demyelination there and some kind of sprouting axons and axonopathy and some kind of problem over the just proximal to the compression area, and this is static. This is a non-progressive Tinel sign. Dynamic or progressive Tinel sign. Dynamic or progressive Tinel sign is where the Tinel sign is progressively going distally. For example, in a neuropraxia of the very commonly in the upper limb, the radial nerve, right? The neuropraxia of the radial nerve, you can have a progressive Tinel sign. Progressive Tinel sign. So how do you elicit the Tinel sign in a radial nerve palsy case in a neuropraxia or oxynotomosis? We have discussed the various types of nerve injuries in another video. Please take a look at it. So neuropraxia or axonotomosis, right? How do you elicit this response? For example, let us say this is the arm, this is the elbow, and this is the hand, right? So the fracture, there was a humerus shaft fracture here. It has been plated or managed conservatively. There was a neuropraxic injury to the radial nerve while it was coming like that, right? So when the nerve was coming like that, there was a neuropraxic injury. Now what happens is the nerve starts to regrow, or the axons start to regrow in case of an axonopathy or a neuropraxia. The demyelination gets remyelinated again, and the nerve starts to conducting again distally from the site of injury. So what you should do to elicit a Tinel sign is percuss from distal to proximal along the surface anatomy of the nerve. So distal to proximal along the surface anatomy of the nerve. So when you keep percussing distal to proximal, the point at which you have maximum Tinels or maximum current shock like experience in the area supplied by the radial nerve is the point of the Tinel sign. So how do you elicit a progressive Tinel sign? Progressive Tinel sign is where you percuss from distal to proximal along the surface anatomy or surface marking of the nerve, and at the point where the maximal Tinel sign is elicited, maximum current shock like effect is elicited, is the point where the Tinel sign is positive. So you must remember the important term here is maximal. So all the terms are very important. Maximal, distal to proximal, percussion, distal to proximal, percussion, and surface anatomy. So each of these terms are very important. So to repeat, percussing the nerve from distal to proximal along the surface anatomy or surface marking of the nerve where there is a maximal current shock like or maximal discomfort to the patient along the distribution of the nerve, along the cutaneous distribution of the nerve is called as a Tinel sign, progressive Tinel sign. So why is this important? So when you have a Tinel sign, Let us take the example of the radial nerve again. So you have the radial nerve which is coming from the arm, then going down to the forearm, becoming the superficial radial nerve here, right? And the superficial radial nerve there, and the posterior interosseous nerve here. So when there is a neuropraxic injury or an axonatomic injury here, then you will have the tinels progressively going distal, or the axons are growing distally, and so therefore when you percuss from distal to proximal along the surface and marking of the nerve, you will find an area where you have the tinel sign which is maximum. So that means the nerve has grown down from the fracture site to up to the elbow, and this can be checked every month, and you can make sure, mark the tinel sign, take a photograph and make sure the tinel sign is progressive. Then you can tell the patient with certainty that the nerve is growing back, and therefore he should make a reasonable nerve is growing back, and he should make a good recovery from this nerve injury, neuropraxia or axonotmesis. So now let us see neurotmesis. What happens in neurotmesis? That is complete transection of the nerve. So this is Seddon's classification type 3, right? In type 3 you have a complete transection of the nerve. In complete transection, what happens is the nerve fails to grow, or when the nerve is cut like this, there are sprouting axons trying to grow, but there is no way to go because there is a gap and the axons cannot find its intended target, and therefore what happens is you have a very significant tinel sign just present over the site of the injury. This is called as the static tinels, right? This is a non-progressive tinels, and this indicates that the patient is having a neurotmesis, and over a period of time, few months, you check and the tinels is still static and not moving. This indicates it's probably a neurotmesis, and you will have to go in and explore the nerve, and unless you go and do something surgically, the nerve is not going to improve or get better. So this is how you differentiate between a progressive tinel and a static tinel. This is a static tinel where there is no progression in the tinel sign, right? And here you will not have the current shock like sensation over the cutaneous cutaneous area supplied by the nerve as well. The tinels is only going to be in the area of injury with no such cutaneous area current shock like sensation. So these are some of the important facts when you are dealing with a radial nerve palsy with a tinel sign. So now let's take another example. So you have a fracture here, a humerus fracture. A patient presents to you with radial nerve palsy 3 months from the injury, right? 3 months from the injury. Then you examine the patient. This is a radial nerve going from the arm down to the forearm. This is a superficial radial nerve. Above is a superficial radial nerve, and below is a posterior interosseous nerve, and you elicit the tinel sign, right? So the fracture is united. Don't worry about the fracture. Now we will worried about the radial nerve palsy, including the wrist drop and the finger drop. So when you palpate and percuss and find the tinel sign, you find it somewhere in the proximal third of the forearm. So now what is the information you gain from this? The information you gain is the injury is probably a neuropraxia or axonotmesis, right? More likely to be an axonotmesis because neuropraxia you expect it to recover within 6 weeks to 3 months, right? So this is more likely to be the feature. So axonotmesis. So why? Because the tinels has progressed from the site of injury, which is a mid shaft of the humerus or the mid part of the arm, to up to the proximal third of forearm. So even without serial examination of the patient, you can make out that the tinel sign has progressively come down, and therefore the probability of him getting a good outcome is very high. You can you can tell this to the patient and tell them that we'll see you after 1 month again, and make sure it is progressively increasing or it is becoming more and more distal, right? So this is the importance of a tinel sign. Even a single point examination may give us some information regarding the prognosis of tinel sign. So where else do you see tinel sign? You see in compressive neuropathies. You see tinel sign in compressive neuropathies like the carpal tunnel syndrome, number 1, cubital tunnel syndrome, where the ulnar nerve is compressed behind the medial side of the elbow. Then you have the tarsal tunnel syndrome, where the posterior tibial nerve is compressed in the tarsal tunnel. Then you have the brachial plexopathy or thoracic outlet syndrome. Even here you can have a Tinel sign positive. Recap. Tinel sign is a very important sign to elicit clinically in many of these patients. We have a static Tinel sign, which could be an indication of a compressive neuropathy, right? Static is a compressive neuropathy, or in a neurotmesis, where you have a complete transection of the nerve, right? Whereas you have a progressive Tinel sign in a recovering nerve injury. The most common conditions where you would like to look for a progressive Tinel sign is one is in the radial nerve palsy following humerus fracture, and the second one is probably the common peroneal nerve injuries which we see commonly with injuries around the knee joint. So it's very important. Just to reiterate, what is Tinel sign, progressive Tinel sign, how do you elicit it? All these points that I'm saying is very important. Percussion, so percussion of the nerve from distal to proximal along the surface marking of the nerve, right? Surface marking of the nerve, the point where you have maximal response or a current shock like or abnormal funny sensation in the area supplied by the nerve is an indication of the point of the Tinel sign. So a progressive Tinel sign is very important to make out to give prognosis of the nerve injury to the patient, and it will help in our diagnosis and charting a treatment pathway for the patient as well. I hope this video helps you with regards to Tinel sign in your exam. Thank you very much. This is Dr. Kannan from Flexus Ortho.